Hello, good morning. Today we have an awesome group here from Hope Healthcare. We're talking about hospice today. It is so near and dear to my heart. I believe so much in the hospice philosophy and palliative care. We've got Dr. Kelly Newcomer from Hope Healthcare, Lisa Johnson, and also Dana O'Connor. And we are going to be like The View today, just talking about hospice and the hospice misconceptions. And I want to start right away just with, the number one thing people say is, oh, I don't want my dad to go on hospice. They're just going to give him morphine and just make him die. So tell me, how do you respond to that? And let's just talk about the misconceptions going on in hospice care.
Okay, I'd be happy to. I think what really happens is that people come to hospice very, very late rather than earlier when they should. So they don't have that time to develop the rapport and the relationship with the staff that I think would have eased a lot of those concerns, because I think it's more like the patient was passing anyway and they received morphine to help make them comfortable during that process, but it was not the morphine that caused them to pass. It was their underlying illness.
And I know, Lisa, you meet with families, and for 12 years I was in hospice and I met with families, and I loved meeting with families and explaining what the service is all about. And how can we have people understand the importance and benefits of getting on hospice sooner and having that conversation, the adult child having that conversation with his or her parent? Talk about that.
Well, usually when I meet with families, I'm being asked to meet with them in a hospital setting or possibly a nursing home setting. And it's after they've had a conversation, typically with their attending physicians, stating that there's probably not a whole lot more they can do acutely to treat or cure what's going on with their loved ones. So they're giving us an opportunity to share with them what we can do to help care for them until their journey comes to an end. And so typically we just have a sit-down conversation, preferably face-to-face, where we visit with the families and anybody who wants to participate in that conversation. And we just openly discuss their goals for their family members. Hopefully, and I hope this for everybody, they've had a prior conversation that when their family member gets to the stage where there is no more curative measures that are offered or available to them, that they're comfortable with palliative care or comfort care measures. And then we talk about what that looks like and how our staff can help meet their goals and expectations of care.
And Dr. Newcomer, you said earlier, when families say, the doctor told me there's nothing they can do. So what are your thoughts on that conversation and that comment when families say that type of thing?
It just makes me sad, because if there's one phrase we could eliminate from modern medicine vocabulary, I wish it were that one, because there's always something more we can do, and especially in a palliative or hospice sense. So I think that when doctors say that to patients, it makes them feel abandoned, instead of saying, at this point, there's no more chemotherapy we can offer you. There's no more treatment for your heart disease. But what we can offer you is a change in focus from cure-based care to comfort-based care.
Okay. And so what does Medicare actually provide when someone agrees to hospice? Explain that, the daily hospice care. What do they get? A nurse every day? Do they have, some people think, oh, they're going to go on hospice and they provide round-the-clock care for 6 months. So explain what the service actually entails.
Would you like me to take that?
Yeah.
So there's a care team that is a part of the care for the entire family, not just the patient. And that consists of a medical director overseeing the care, like Dr. Newcomer. And then we have case managers who are registered nurses. And then we have hospice certified nurse assistants who are hospice aides. And we have social workers like Dana. And we have chaplains and then volunteers and ancillary staff to assist with the whole care of this patient that's on service with us. So what it looks like can be very different depending on when the patient comes onto our service. If the patient comes in the middle of crisis, then their routine is going to look very different than if it's routine care. But typically routine hospice care would be a nurse visit, usually twice a week, with our company, and daily aid visits Monday through Friday, and then periodic visits from the social worker or the chaplain.
So Dana, do you get to see all of your patients? Do you what do you do in your role?
I provide a psychosocial assessment, which entails just sitting with the patient and family and discussing their goals. One of the questions I like to ask is, what are your expectations for care? And oftentimes we'll get kind of a standard answer, well, I want them to be kept comfortable. I want them to be pain-free. But every once in a while, you'll get a very unique answer, which I always enjoy hearing. So I do the psychosocial assessment. I assist with advanced directives. I think it's very important for people to discuss with their families what their end-of-life goals are and their care. Some people want certain treatments withheld. They may say, I'll take oral antibiotics, but I don't want IV antibiotic therapy. And so we help with all types of end-of-life documents, like the directive to physicians, which specifies treatments that they want or they want withheld at end of life. Medical power of attorney, which designates somebody to act in their stead if they become incapacitated or just choose to defer that to a family member. And then an out-of-hospital do not resuscitate if they choose no heroics at end of life, and just to be able to die naturally and comfortably in their own home. So a large part of my job is just to sit with them and provide emotional support to the family.
That's nice. That's nice. So just talking about continuous care, that misconception that when you go on hospice, you have somebody with you around the clock. Tell me how, if somebody were to be in a crisis, give me an example of a recent patient that went in crisis and maybe went on continuous care and then came off continuous care. So it's not always those final 2 or 3 days of life. And people are very confused on that because with private duty, a lot of times we have patients that are on hospice that even though they've got somebody with them around the clock, they don't meet criteria to have a crisis care nurse. So can you kind of share that, Dr. Newcomer, on just that misconception?
Sure. I think it's very important to realize that Congress enacted the laws to create hospice care to come alongside a family who is caring for their loved one at home, because it's very challenging. But it wasn't to provide the care in the home. It was to assist a family in providing that care. So in routine care, the nurse is going to do teaching and show you how to set up medications, but they're not going to be there around the clock. But Medicare does specify that if there is a crisis, meaning that the patient is requiring a nurse skilled level of care to be comfortable, then hospice can temporarily put a nurse at the bedside 24 hours a day to get control of a particular symptom, such as uncontrolled pain, shortness of breath, agitation, something that's happening that's really requiring a nurse to make minute by minute, hour by hour decisions in the care of the patient. Once that symptom is controlled or that crisis is over, then we will return to a normal level of home care.
Okay, and you know there is a lot of competition out there. There are a lot of hospices, and I was on the giving end. I was also on the receiving end. My grandmother was on hospice. She lived with us. We had a wonderful experience. My father's experience with hospice was not so great. The group home he was in sold his Social Security number to a hospice and was put on hospice without us even knowing he was being put on hospice. It was a terrible, terrible situation. We did do the necessary calls. We took him off service, and but we are healthcare. I'm a healthcare professional, and this kind of thing can happen to anybody, So how, with all the hospices out there, how do you know the difference between what sets Hope apart? What is it about you guys? And I know we have met and had lunch the other day, and I am so impressed with the job you all do and what you offer to patients. And when I was a hospice nurse, right out of nursing school, when somebody was in the dying process, everybody was there. I saw my patients 3 times a week and still went to team conference. I made sure that our patients, the rule was don't have visits on the weekend. Make sure they are tucked in and they're good until you go back on Monday. So a lot of hospices right now may offer a nurse every 2 weeks. We had one the other day. The family was so upset. The nurse would not even call in refills. It was the family's responsibility to call in refills for medication, for hospice provided medication. So there are just a lot of horror stories out there. So what sets you guys apart, and what should a adult child that is looking for the right hospice and wanting the best care for their mother, and they're told by a social worker at a hospital, I'm required to give you 3 names. And sometimes that's what a case manager in a hospital will say. I'm required to give you 3 names. I can't make any recommendations. So what is it about Hope, and what is it that questions that people should ask so they know they're going to be in the right hands when they go on hospice?
You're asking me. I've been a hospice consultant now for about 4 years, and Hope was not the first company that I came to work for. And I chose to come to Hope because I felt that our administrator and owner, Chad Higby, really emulated the philosophy of hospice care that spoke to me. I consider what I do kind of my ministry. It's a calling. I don't think it's for everybody. And I feel like everybody who works for this company feels the same way. We all have the same heart and same passion. We want to make sure everybody's experience on our service is the best and the most positive that we can make it for them. So what sets us apart is that we are locally owned and operated. Mm-hmm. We have 2 offices currently to serve the Dallas Metroplex, and we have just a fantastic staff of employees that our staff to patient ratio, I feel, is a lot smaller than some of the other hospice companies in the area. And there are hundreds of hospice companies. Families get very overwhelmed if they go on Google or if they try to find hospice care on their own without some guidance and some support. So oftentimes they'll do their own research, or they will ask for a recommendation from somebody who has prior experience with a hospice company. And I always recommend, when I meet with families, do your due diligence, talk to everybody, find out what the experience was. If you have the name of a nurse or somebody that you felt really gave exceptional care, that you can pass that information on. We all know we like to look at reviews. We like to check to see what other folks are saying about the company. I recommend that people do due diligence, really find out what you're signing up for, so to speak, because I feel there's some companies that are in this industry not for the right reasons, not the same reasons I do what I do. And I feel it's important that people have a confidence level with who they're working with and know just the heart of the company. And I've said this earlier, but the largest doesn't mean the best. The staff to patient ratio, I think, is most important. We have several medical directors, lots of nurses, several chaplains and social workers. I think our employee to patient ratio is almost 2 to 1. It's really, really a good ratio in this industry. And so I feel as though our particular company, Hope Healthcare, I can honestly say with pretty good assurance that most everybody within our company knows all of our patients or knows something about all of our patients. Not every hospice company has that familiarity with the people we serve.
But what about that adult daughter who is an attorney, and she's got 3 teenage kids, and she's told, well, there's nothing we can do. You need to pick a hospice. He's going to go on hospice on Friday. It's Thursday. And she's overwhelmed, and that's sad to, that she has 10 minutes to look at reviews on the internet.
That's why I say recommendations, if she can find one, are very, very good, because sometimes in the hospital setting, there are different levels of hospice care. And in hospital, hospice care is one of those options. It's called general inpatient hospice care. Sometimes families don't even really get a choice. It's whoever is available at that time to help the family and in the hospital, because they may not have a day or more to make a decision. And so you hope that somebody is there to answer all their questions and to provide them with the appropriate answers they're looking for, and the care that they want to receive is being offered as quickly as necessary. It can be a very stressful time, and I feel that talking to a lot of strangers right before you make a very critical decision can be very overwhelming. So recommendations, personal recommendations, Dr. Newcomer, I mean, you may have some thoughts on this as well. Just really getting a good feeling that you're talking to somebody who's telling you the truth, not just trying to get your business.
Well, and I would say request a social work consult. I mean, request to speak with a social worker, because they're the experts in understanding what resources are in the community.
And I do appreciate that. One of the things that Lisa spoke about, and I believe the same way, to me it's a vocation. I mean, you don't go into this for a paycheck. You have to do it because it's a labor of love and it's a calling from Christ. And that's why I do it. But the corporate hospices, I've worked for some of those in the past, and they'll give you a quota. You need to see X number of patients a week. And with Hope, it's not that way. And just yesterday, I met with a sweet little lady, and she couldn't speak her name, and her daughter had traveled in from Oregon, and we were sitting there, and she's saying, "You are my sunshine, my only sunshine," so beautifully. And I got to spend like an hour talking to the daughter and the family. But I think you're right, Dr. Newcomer. To me, it's trying to find that fit and saying, meet the nurse. If that's the person that you're going to be with, ask to speak not only with, the hospice consultant, but ask to speak with the nurse who's going to be in your home and on the team, and find out if that's a good fit for your loved one.
That's right. And one thing I can say is we are guests in their home, whether it be private duty or hospice or home health. And if a nurse is rude or it's not a fit, or for whatever reason the patient's not comfortable, they can ask to switch and have a different staff person. We're guests in their home. Well, one other question sometimes I would have, with our hospice patients was, well, this nurse is making all these decisions and I want to see a doctor. So, they've told me I don't have my doctor anymore and I'm now with the hospice doctor. So how do you all approach patients that want to see the doctor and they want to see that hospice doctor? And a lot, they just get reassurance talking to the doctor instead of going through the nurse or the nurse practitioner. So tell me your thoughts on that.
Well, that was one of the things that really attracted me to Hope, because I actually started in hospice just making home visits. I didn't do any administrative things. I was hired just to go out and see the patients in their home for that very reason, and just really fell in love with those patients. And you can know in 5 minutes in somebody's home how they're doing versus in your office when they show up after 2 hours of preparation and they look great and they've got their best face forward. But when you're in the home environment, you really get a sense of how someone's doing, especially if you're seeing them over time. And so that's very important to me, to really assess the patient and see, what are our needs. And the other thing is, hospice nurses are some of the greatest nurses out there. They're really able to operate fairly independently, but they still sometimes come to me and say, "Hey, I really need your help. This is a particularly difficult case. Please go make a visit and give me some suggestions." So it really does take that whole team. And I think we need more physician involvement. I think the days of someone coming onto hospice, being alive for 5 or 6 days, and palliating at the very end of life are over. And the days of physicians not being able to go out and look at the patient firsthand are really past. And this new model of hospice, where people come to hospice with very complex problems that really need the entire multidisciplinary team to be able to see them in their home. So I'm very committed to making home visits. And I also take learners, medical students, residents, fellows in hospice and palliative medicine out with me to see what home hospice looks like.
Are you seeing doctors, residents, and interns interested in hospice care?
They very much are, because they don't get a lot of that training, although we're really trying to change that at our medical institution. We're really trying to expose them a lot more to hospice and palliative medicine, and really teaching them how to have good goals of care conversations.
That's awesome. That's awesome. Well, I know having a doctor visiting the home is ideal. I mean, it is ideal, and it's something. Another question people ask me is, there are nonprofit hospices and there are for-profit hospices. And so I'm going to put you on the spot, Lisa, and just ask you, what is the difference when somebody says, oh, I want to go with a nonprofit hospice because everything goes towards patient care? Can you address that and tell me your thoughts on nonprofit hospices in general?
The majority of hospices in the Dallas-Fort Worth area are for-profit hospices. There are a few not-for-profit hospice agencies, and please chime in, the rest of you, if you have any thoughts on this. But from my understanding, we are all reimbursed the exact same way by Medicare. So Medicare dictates how we get reimbursed, or insurance companies will reimburse for our services if it's not a Medicare patient. The payment and reimbursement is the same. What the companies do with that money may be look differently. So whether you're for-profit or not for-profit, you're getting the same amount of reimbursement for the services rendered. Now, some companies will use that reimbursement and have nurses, as you mentioned earlier, come once every 2 weeks to make visits. We actually have nurse visits 2 times a week, generally, on our patients. So you can see the companies that send a nurse once every 2 weeks versus the companies that send a nurse twice weekly are getting paid the same amount of money for those visits, or as a collective amount of money, and they're just utilizing it differently. So I can't testify to the exact way nonprofit companies use those resources that they receive, but they're the same as every other hospice company. So it's just a matter of what they choose to do with their profits and their fundraising that they may have outside of the reimbursement they receive, and how they utilize that money.
Okay. And then kind of last, I want to talk about dementia patients and hospice care and palliative care. I know with my mother, she had dementia for 9 years, and she finally qualified for hospice. And until that time, it was out of pocket. She didn't qualify for home health, for Medicare home health, because she wasn't rehabable. She wouldn't take any medicines regarding like dementia medications. And so it was a long process. It was an expensive out-of-pocket process. So with dementia, how do you qualify for hospice care for the dementia patient? So can you explain that a little bit too?
Sure, I'd be happy to. Dementia is really difficult to determine what prognosis is. And in general, physicians are bad at determining prognosis. There are all kinds of prognostic tools out there, but many of them, when tested, are kind of 50-50 anyway. So it's very difficult to decide. After years of doing this, one of the things that I really rely on is our nurses. And although technically we use a FAST scale, which is a functional assessment and staging in Alzheimer's, that scale really applies to pure Alzheimer's disease. And there are many, many kinds of dementia. And most dementias in very elderly people are mixed. They may have, some component of a previous stroke, as well as some Alzheimer's, as well as a little bit of Parkinson's. So it's hard to just call it one thing. But we still use that scale because, generally speaking, when people are what we call fast level 7, which means that they are losing the ability to speak and losing the ability to walk, those are criteria that Medicare is looking for to decide that someone is ready for hospice. So that's kind of the minimum that we're looking for. If you are still walking and talking, you're not ready for hospice. As difficult as it may be to care for that person, your prognosis is very unlikely to be 6 months or less, which is the Medicare standard. So we're looking for other things like frequent infections, nutritional changes, the inability to eat well, or even if you're eating well, still losing weight, things that to us say we're in that last 6 to 12 months of life.
Okay. And do you all have a lot of dementia patients?
We do. And it's interesting because if you look at hospice care in America 25 years ago, the number 1, 2, and 3 diagnoses were going to be cancers. And now that has really changed. As we've gotten better at fighting those other illnesses, we've had much, much more dementia plaguing our elderly population. So neurodegenerative disorders like Parkinson's disease, like Alzheimer's, like stroke are going to be way up high on the list now. And those patients tend to live longer on hospice than cancer patients. So one of the things that Medicare is looking into is, we're spending a lot of money on hospice. Are we really doing this correctly? So the onus is on us as the providers to make sure patients really meet those criteria and not put them on way too soon.
And one thing I used to get as a hospice nurse, a patient that is in-stage dementia that is not swallowing anymore. And the family brings up, oh, well, mom is starving to death. Or she's going to need a feeding tube. Mom is starving to death. How do you approach that question with feeding tube at the end of life versus no feeding tube?
Well, I think there's a misconception that a feeding tube is A, going to provide better nutrition, and B, prevent food from going down the wrong way, what we call aspiration, where food goes into the lungs instead of into the stomach. And although feeding tubes can reduce that risk, they do not eliminate it. And eventually, that food will still go down the wrong way. So it's a big problem, but the feeding tube is not the answer. And the other problem that I try to educate people about is that end-stage dementia patients lose weight even though they're getting sufficient calories, because your brain is in control of all these automatic processes in your body. And one of the things your brain controls is emptying your stomach and digestion. And those things are incredibly delayed in dementia patients. So you can put nutrition in them all day long through a feeding tube, but they are proven that they do not prolong life, they do not improve the quality of life, and in fact, people still continue to lose weight. And when we overwhelm their system with too many calories, you just get malabsorption and discomfort and aspiration. So they are not good for end of life, and we just need to do a better job of educating people that this is not the answer.
Another misconception is they're going to be thirsty and wanting IVs at the end of life, IV fluids. So can you address that as well, the negatives of getting those IV fluids in the dying process?
Yes. Fortunately or unfortunately, however you look at it, being a little bit dehydrated at the end of life is actually a good thing, because when we give people who cannot process fluids any longer IV fluids, instead of keeping it in their vascular system where it hydrates you, that passes into things like edema and congestion into their lungs, and can actually make the dying process a lot more difficult. So, most importantly is keeping the mouth moistened and making sure people don't have a dry mouth. That is mainly what bothers people at the end of life. It's not dehydration per se.
Okay. So if somebody wants some information, they're just kind of like preparing for college for their kids. They know their loved one is getting older, and they want to have all their ducks in a row, and they know that dad doesn't want anything aggressive done, can they meet with the hospice just to kind of pre-plan for that
Absolutely.
time? Would there be any charge for that?
No charge at all. I'd be happy to meet. I meet with families all the time just to answer questions. Oftentimes, as we were alluding to earlier, sometimes I will get a referral to visit with a family when they're not quite ready for hospice care. And so I have the opportunity to share with them. They're hoping for some extra care. They want some more help with in the home or in their care, their environment that their loved ones are in, and they're seeking a consult or an evaluation for their loved one, just to see what it will look like when they are ready. And I'll have those conversations with them. Our whole team will. And we'll talk to them about appropriateness of starting care when it's not appropriate, and just answering all of their questions. And then we're a resource to them. And when they're ready to make that decision, I'm always happy to give out my phone number and meet with them, either by phone or in person. I'm happy if I'm available to do so.
Okay. And then one other question, and I've had these questions too. At the very end of life, what is the hospice's role? Because I've had people say, my dad's not going to want to die in our home, or my mom's not going to want to die at home. They won't be able to go back or sleep in their bed anymore with a spouse that's gone. How do you address that if somebody is on hospice but they don't want to die at home? What are your comments and suggestions, and how can hope still help in that situation?
I think one of the best benefits of hospice is that it is an interdisciplinary team approach. I think of it like the four chambers of the heart. I'm no Dr. Newcomer, but I'm going to give this a shot. Because the four chambers of the heart, I think, with our bodies, we have four major components. We have our minds, our emotions, our spirituality, and our thoughts. And it's just, mental, emotional, physical, and spiritual. Thank you. And I do ask that question, especially if there are children in the home, that can be an issue. And so that's when myself as the social worker would come in and talk to them, give them resources, maybe sit with the kids and ask what their thoughts are, give them resources about how to talk to children about death and dying. If they're adamantly opposed about dying in the home, and that does happen where like a young mother would unfortunately would not want to die in the home, then we, have access to general inpatient resources that we can put somebody into.
So they can still go those final hours. They can still go to the hospital.
They can. And so we have contracts with people, and then the chaplain comes in, and we just really, my biggest goal is, just what does the family want? What are your goals? Because we only get one chance to give them the red carpet treatment at the end of life. And so, it's our goal, it's our mission to do that the right way. And I think in large part the best way to do that is just to listen. The families are telling us what they want. It's just to be mindful and to be respectful and to give them the dignity, even if it's outside of what we may want for our own families, to honor them in the way that they see fit.
I know, and you all do such a wonderful job, and you've got a wonderful reputation in Dallas, and it's just been an honor to have all of you as guests. And how can they reach out to you? I know we're going to have a website. What is the phone number they can call?
Oh, yes. The phone number for Hope Healthcare is 972-366-5030. And I think they might have it on the screen, and it will be available. But again, it's 972-366-5030.
Thank you, Dr. Kelly Newcomer, Lisa Johnson, and Dana O'Connor. Y'all have been awesome guests and just talking about hospice. And thank you so much for your time and answering these questions. And I hope this is helpful to our listeners on what a benefit hospice is. Thank you. Thank you so
Jill.
much.
So you stay,